Hello, everyone. I'm Dr. Mapola McLeod. I'm a naturopathic doctor here with NutriChem.
And I'm Grace Meehan, and I'm a clinical pharmacist with NutriChem Pharmacy, and I'm also a certified menopause practitioner with the North American Menopause Society.
Yeah, and I love speaking to you, Grace, about hormones. It's something that we always talk about all the time. I'm always visiting you in the dispensary chatting. So
That's nice.
today's video, we wanted to talk all about hormones and estrogen and trying to kind of break down the concept that there's always fear and hesitancy around estrogen. It stimulates almost like a visceral response in some people when we talk about estrogen. And
It
we're
never
hearing,
goes away, every day in the dispensary, or like women are always, they always have that look on their face of, oh no, is it safe?
I know, is it safe? Or, oh, I don't want to have cancer, and I think right off the bat, and we're going to talk about some of these things, but I just find it really interesting that we have, the birth control pill is estrogen. It's a strong synthetic estrogen, and it's probably one of the most popular prescriptions out there, and we don't blink giving it to people. Yet when our hormone levels drop to nothing, we're so afraid to even bring up estrogen. So I just find it kind of
Right. And the
counterintuitive.
doses we would use are so much smaller than
So much
what is in a
smaller.
birth control pill. Yeah.
Yeah. But when it's kind of marketed as birth control versus replacement, I find it's really interesting how different the response is.
Yes. Yeah, absolutely.
So today, okay, so we're going to talk about a couple things, but firstly, we wanted to talk about how do hormones actually impact you. So we talk about, and we hear this day in and day out, we're always talking to women, but what are the biggest areas that hormonal changes can impact women? What do you think?
Well, I think first we have to even speak of the basics, which is that we have hormone receptors everywhere in our bodies. Often we think it's just in the reproductive area, but they're everywhere. They're in our brains, they're in our muscles and our joints, it's everywhere. So symptoms can be wide and varied. So of course, right, and when we think about hot flashes, for sure, that's the signature symptom of menopause and perimenopause as well. But there's also, second biggest symptom is genitourinary syndrome of menopause. So that's vaginal tissue health. The vagina dries, it becomes uncomfortable, changes happen there. And the third major symptom that people don't even think about at all, it's arthralgia. That's muscle aches, joint pains. Women experience that, especially postmenopause. It's a really big one. Mood, sleep, libido changes.
Yeah, for sure. And I think, sometimes we think, oh, I'm like my hot flashes and night sweats aren't so severe, so it's not that big of a deal for me. But I often talk to women and, their sleep would have been disrupted for a year or two. They used to sleep fine, and all of a sudden they're waking up in the night, 2, 3 a.m. Their mind is racing. They're not able to fall back asleep. There's been period changes happening. And, what I often talk to women about is you're having plus or minus 7 days where your cycle used to be regular, and all of a sudden it's becoming more irregular. And then you're also having symptoms like sleep disruption. And again, we know now that a couple nights of disrupted sleep really can significantly impact your mood. So anxiety levels, irritability, that flightiness, and you're much more likely to overeat the next day after disrupted sleep. So then it starts to creep into weight changes as well. So it's kind of this whole snowball effect that, we don't even realize is attached to hormonal changes.
Yeah, and it's women perimenopausally. So we're talking about before the last menstrual period, by 10 years or so, that really start to experience those symptoms, but don't put 2 and 2 together, that it's their hormones. And they're thinking, why am I irritable? What's going on? Why am I not sleeping? Why do I not feel like myself? And the frustrating part for them is they can go to their care provider, and what happens? They get prescribed an antidepressant or a sleeping pill, or, just it's not looked at as a hormonal issue. And then
Mhm.
when it is, and they get some proper treatment, it's like a home run. They're like, wow, like I feel so much better. Yeah.
Yeah, it's such a huge game changer, and there's so
Yeah.
many trickle down effects. You're even mentioning the genitourinary symptoms. We can talk about libido all we want, and when we talk about the vaginal changes, though, if you still have libido, like if your mind is there, but physically intercourse is extremely uncomfortable. Not only is it not pleasurable, but it's actually uncomfortable and painful. That's going to be an area that, women just kind of close out of their lives because they think, well, this is just not something I want to participate anymore. And that can have impacts on
Oh,
relationships. Like it's
yeah. And we know, right, that there's benefits of having sexual activity in your life. It decreases your stress level, it decreases blood pressure, it increases your mood, your relationships. So it's, closing the door on that has health benefit or health issues.
Yeah. And I mean, I hear it all the time. Women say, well, how come I'm the only one? Like, how come nobody else is dealing with this? And I always say, I'm like, this is so much more common than you think, but we just don't talk about it.
We
And
don't talk
that's
about
why,
it.
people think that they're the only ones, or they might not want to ever mention it,
Mhm,
because it's
mhm.
such and so it's
But we
interesting.
have to talk about it. We have to educate women. Every woman who's going through a menopause should be asked, how is your vagina?
I agree. And how are you sleeping? And how's
Yeah.
your mood? Not just, okay, no hot flashes, no night sweats, let's move on. And like I said, and what Grace, you probably see too, is these other changes to what I see in my practice happen far beyond when really significant hot flashes and night sweats start.
Mhm.
It's kind of that slow creeping in where the PMS period can extend, especially if
Yes.
you see where there's big changes happening in the period. If a woman used to have maybe severe anxiety or low mood before the period, that can then extend to like 1 week or 2 weeks in a cycle where they're just not feeling like themselves. They're teary all the time. They're
Oh.
snapping at their family.
How do
Con-
they do their job, right? How do you
yeah,
raise kids? How do you function? It's
yeah.
quality of life to the nth degree. It's terrible. Yeah.
Yeah, and these women, and I mean, this is the conversations, like women are at the peaks of their careers, they're
Mhm.
running families, and they're expected to function at the same level they were functioning at before, while
Mhm.
there's massive hormone swings happening. And it's just wild that we put these expectations on women and don't talk to them about, okay, well, you're putting a lot of pressure, there's going to be a high amount of stress, but you're also dealing with this on top of everything. And it's normal if you don't feel like you're able to cope like you used to, because you do not
Mhm.
have the same, your chemistry is different.
Mhm. Absolutely.
So let's talk about some things that women can do, because it is a spectrum. We don't go from 0 to 100 in terms of just giving everybody hormone replacement therapy, because it can be such a long progression. So there's often a lot of stuff we do before we even bring in hormones in order to help stabilize and calm everything down and help support these hormonal changes that will inevitably happen. It is biology, it's
Yeah,
going to happen. It's just helping support women and educating them along the journey.
exactly.
So, what
And
would
we
you
and we
say?
find we find that women do better when once sort of the groundwork has been laid before you add in hormones, right? Because there is so much that we could be doing wrong that needs a little bit of, no, wrong might be a strict word, but like things could be improved so that they do feel better. So we look at, what are you eating, right, Emma? What are you eating? Our North American diet is chock full of processed sugary foods that we know disrupt our hormonal balance.
Mhm.
Um,
Yeah,
alcohol is another one that is
yeah.
wreaks hormone havoc in women. Exercise. How are you sleeping? So, and nutrient deficiencies as well. We will
Yeah.
look at that. They'll look at what's your thyroid hormone doing. Potentially, the thyroid is off. So many women experience thyroid issues in their 40s, like 1 in 5, I think, is the statistics. So that gets looked at as well. So
Mhm.
there's those things that we have to look at first and have a good conversation with women.
Yeah, and often that's like, those the changes that we make are often enough to have such a significant impact that we don't
Yeah.
necessarily even need to bring in any hormones for quite some time, if at all. And, recognition that just because you used to eat a certain way and be able to function, when your body is going through such
Mm.
significant changes, it will respond very differently. So your sugar control in the past, and it's as we age, this happens, but you might have been able to tolerate highs and lows of sugars throughout your day. But when your hormones are also bouncing around and you're in a premenstrual time where your
Yes.
estrogen is bouncing and your sugars are bouncing, that can trigger massive mood swings, really crazy problems with focus and concentration,
Hmm.
irritability, and then you're more likely to eat more and gain more weight because your estrogens are changing, and that has an impact on weight distribution. So gaining it more in the middle versus around like the hips, thighs, breast tissue where women normally would gain weight.
Hmm.
And then recognizing you're more likely to reach for these quick foods, processed foods, because you're
Yeah.
becoming more sleep deprived and your mood is low. So starting to kind of understand what's happening so we can kind of stop that cycle, because
Mhm.
it has such a huge impact on mood and energy and concentration, but recognizing that it's not the same as it used to be. And because women are like, well, why? Well, I always have had, a glass of wine with dinner. Why do I need to stop now? And it's like, because there's changes, and this can have a significant impact on your sleep because it's so fragile right now.
That can be so profound. Just looking at alcohol intake,
Yeah.
it's so profound, right? Because it really impacts
Yeah.
quality of sleep. And when sleep is disrupted, everything feels worse. You're not going to make your important neurotransmitters, serotonin, dopamine. It disrupts everything.
Oh,
You lose your joy oftentimes when you're having that glass of wine every single night, and the weight
yeah.
comes off when you really look at that, and
Yeah,
that's a real
it's
win.
so
Yeah.
drastic. And that's why I often challenge women. And, we don't have to live in, it doesn't ever have to be like an all or
Yeah.
none. But often what I say is like, let's take it out for 3 to 4 weeks,
Yeah.
because they're like, well, it doesn't impact me. It really doesn't. And I hear that all the time. Well, I'm like, okay, well, let's just see. It might not, but more likely if you have a hot flash at night and you cut out your wine, your hot flashes will either significantly decrease or actually go away completely. And
They
then when we
do.
start
Yeah.
regulating sugars on top of reducing the alcohol, then mood, weight, like everything can start to fall into place. And then we add in the nutrients and the protein, and often, people feel so much more balanced.
Alcohol just becomes a real habit for people.
Yeah.
It's like that daily, I'm making dinner, I'm going to have a glass of wine while I'm making dinner. It just becomes that habit
Mhm.
that, after a week, you break that habit and you're not looking for it anymore. That's what I've found with the women who have, made look at this, that everything gets a little easier once you break that. Oh, it's a dinner time thing, or it's something I do as I come home from work to decrease my stress. Well, it doesn't actually decrease your stress in the long run. It can
Yeah.
exacerbate it.
For sure,
Um,
100%, and mood and energy the next day. So yeah,
mhm.
that is, those are definitely the top things I would say is getting those triggers out or reducing them significantly so that we can kind of start to peel away the layers of what is the baseline of hormone changes, not just triggers disrupting everything that's already kind of in a disruptive changing
Mhm.
pattern.
Mhm. And
And
we look at
so
the health of the gut as well,
yes,
big
yes,
time gut, like
yes.
fiber, the microbiome. How are you eliminating? How many bowel movements per day? I
Mhm.
find it uncanny when I ask a woman, how many bowel movements per day? And they'll say, oh, one every 3 or 4 days. And I said, that's not normal. They'll say,
Mhm.
well, that's normal for me. No. So, improving that is key for
Oh, for
actually for
sure.
hormonal balance. Yeah.
Well, when we talk about estrogen, when we talk about when women are worried about hormones, and we talk about, your own endogenous hormones, your hormones that are being released all the time from your ovaries, a lot of people don't understand your hormones are released through the bowel movements. So,
Yes.
and we have bacteria in our gut, unfavorable bacteria that have activity when your body, your liver sticks a tag on estrogen and says, and the tag says exit the body, like this is to be released. There's a lot of bacteria that will chop that tag off. And so the estrogens get recirculated. So if you think about it, if you're not eliminating consistently your estrogen levels,
Yeah.
you have a ton of estrogen recycling going. So this is why it's important to work with someone who understands hormones, because a lot of the studies that we did, they just gave anyone like they would never assess for bowel movements, but we know now we would never pile on hormones to a woman who's not eliminating and detoxifying. That's not
Exactly.
a
And
good.
that extra pylon of estrogen makes women feel so awful. The breasts are tender, there's headaches, there's anxiety, just all those estrogen excess symptoms that come along with that.
Yes, exactly.
Elimination is important.
Exactly. Elimination is super critical. And then plus making women feel, because, again, with the weight changes that can come on and people just saying like, I don't feel like myself, reducing bloating and inflammation, not just fat loss. When women lose weight fast, or when you remove alcohol and sugar and you're like, wow, I've dropped 5 to 10 pounds in 2 weeks. That's not fat burning, that's inflammation and water retention, weight coming down, but that can make people feel so much better. They feel less sluggish, less swollen, less weighed down. And so it's very inflammatory, and that can make your mood improve as well. So we kind of wanted to talk about the hormone changes through a woman's life cycle, just to kind of break down I think looking objectively, I know for me at least, when I see numbers objectively, it kind of takes the fear away a little bit, because we see the massive spectrum of estrogen levels in a woman's life. And it kind of seems comical to me when we get so afraid of these micro dosing of estrogens, when in relation to where you were like 5 years ago, it's negligible.
Right.
So, okay. So the first note, Grace has some numbers we're going to hold up.
Yes.
So these are averages, but okay. So pre-puberty, ovaries are not turned on. There's no estrogen being released. Once puberty starts to hit and the menstrual cycle starts to become irregular, there becomes a cyclical pattern of estrogen release, stimulation of ovulation, and then dips in estrogens before and changes in progesterone in relation to those estrogens. So in a menstruating woman, regular cycle, we wrote an average. You just hold it down a little bit. Average, we say about 700 picomoles per liter of estradiol, 17-hydroxyestradiol. So that means, and there's a range. There's a range. It goes, I would say we often see between 500 to 1200, but that's kind of ballpark. And that would be done in the luteal phase, like the phase before you get your period. That would be average levels of estradiol for a woman who's having a very regular menstrual cycle. So you can kind of get an opinion of that. And then moving forward, when perimenopause starts to hit, that nice smooth, I guess no, let's talk about pregnancy. So then
pregnancy, that's the fun one.
Pregnancy. So I'm pregnant. These are my levels. So we know where they're at right now.
This is so fun. The day you came in the dispensary to show me your levels.
I was like, oh my God. So pregnancy comes along, and let's see your level. Let's see. These were actually my level, 17,000. So 700, my levels are, and 17,000, like again, range up to 25,000, 30,000. So
it can be 10 times your normal level.
10 times your normal level. So your body is surging estrogen levels. And I think it's, at least for me, I found it kind of comforting seeing those in relation to the levels we do with HRT, because you're going to see those soon, where estrogen is not the enemy. Just because there's something scary that has a receptor for something, it's not that simple. Having more does not equal that. if that was the case, every single woman who's had a pregnancy would be at severe risk for breast cancer.
Exactly.
If we were looking, and that does not, there's a lot of research showing protection of nursing and pregnancies against breast cancer. So it's not as simple as levels cancer. And so this is why we wanted, like, this is why I think it's cool to look at these numbers, because you can see how much estrogen your body can actually take. And when we're pregnant, we know there's pregnancy brain, there's all sorts of changes, but look at that change. So once you have your baby and then you go back to a regular cycle, you have to get from like 17 to 20,000 back down to that 700. That's a math. And when you're nursing, your cycle is suppressed. So you're not ovulating. So your levels are actually probably, like, your levels can be in the 200s, 100s, like they can be really low. That's a mass drop. This is why women get severe hot flashes, night sweats postpartum. This is why there's massive mood swings.
They lose their hair.
You lose your hair, but just crazy amounts of anxiety, postpartum depression, like, and then on top of course, there's sleep deprivation and everything else. But just talking hormonally, that's a huge drop. So when women are like, why do I feel like this? I'm like, look at these numbers. It's a wild roller coaster down afterwards.
Yeah, it's great to see the numbers, honestly.
Yes. And so, okay, so then pregnancy, regular, back to the, eventually after you, if you choose to nurse or not, whatever, you're back up, eventually we'll probably get back up to the 700 levels. Then perimenopause starts to hit, where you lose that nice cyclical stimulation from the brain sending those ovulation signals. So it's kind of this like sputtering of the ovary. So some days you have 700, the next you have 100, then the next. So it's really a roller coaster, and there's no rhyme or reason to estrogen levels at those points. So you could see how adding in alcohol, sleep deprivation, sugars already can really start to screw that up. And we don't even have an average. We couldn't even write it on a piece of paper for perimenopause, because literally, there's nothing we could write that would be an average that we see, right? Because it's so all over the place.
Yep. It's a roller coaster.
It's a roller coaster, but eventually ovulation will stop. Eventually your ovaries will stop, and so they will stop releasing estrogen. And when your ovaries stop releasing estrogen, this is what your levels will be at. So this is a normal menopause level. So less than 60, and some of them are even less than 30. So you go from 700.
It's hard to measure at that point.
Yeah, it's just not really measurable, to less than 30. Again, mass drop. This is why you have these big swings and huge changes, and we're trying to function. We don't have any circulating estrogen.
That's why all those parts of the body that were dependent on some hormones,
bones,
you get symptoms.
Yes, brain, libido, and I always say, I'm like, imagine men's testosterone went down to 0, like guaranteed it went down to 0, it would, have a massive, like, how could you work? There'd be mandatory testosterone injections.
Yeah, it'd be a different story altogether.
It'd be a different story.
Yeah.
Okay, so then the woman is not sleeping, super irritable, no libido, doesn't feel like herself, achy, feels like she's just aging overnight. We decide to bring in some hormone replacement therapy. She's a good candidate for it. We've supported everything else. Elimination. When we give hormone replacement, these are kind of the numbers we would get at if these numbers. Did you write down the hormone replacement one?
No.
Oh, okay. Well, I have it, but I don't know if it's going to be backwards, so I'll put mine up. I wrote about 100 to 150. So that's kind of even on the higher end of the range, but we don't ever really go above 200, I would say, picomoles per liter.
Right. And there's good data to support what you wrote down as being good for bone health. Right? You've got to get it up sort of high enough. for the
Yeah,
bones too.
and often women, a lot of the times when we test their estrogen levels after they've been on hormone replacement, it doesn't even break that 60 threshold, but they feel
Yeah,
so much better. They feel like, oh my God, okay, I am sleeping, I don't have hot flashes, my mood is stable. We haven't even hit the 60. Like we're not even getting
that's
near.
how quickly vasomotor symptoms can go away.
Oh my gosh, it's wild. And again, like we would never get you to a point where there's even close to a cycle happening again, no bleeding, anything like that. We don't want to stimulate anything. It's just enough so that you can have some of that action of estrogen. And then of course, we're not talking about progesterone today because progesterone doesn't have the same, I don't know, people don't get as fearful of progesterone. Do you find that?
Absolutely.
Yeah.
Absolutely.
Yeah.
Estrogen seems to be
Estrogen is really the
the
trigger one.
word.
So
Yeah.
hopefully you guys found some benefit. We'll kind of summarize. I'm going to summarize that.
Mhm.
We'll do a little write up, but hopefully people can get a little bit of relief knowing that we're not even coming close to the levels that they previously were at.
Yeah.
And so let's finish up then if women are considering hormone replacement and they've already worked with someone to really kind of hone in on those key other triggers and gut
Yeah.
health
Clean
and
things
that
up.
sort of
Yeah.
thing. What are the conversations, Grace, that you often have with them prior?
Conversations prior. Well, certainly we dispel any fear. I'll go through the data of the studies, sort of concisely, to talk about what they might be afraid of. Some women are not afraid at all. They've really gotten some education or they've done some reading. I find a lot of women are really looking to get the true picture now, but there's certainly some who are still fearful. So we'll dispel that. We'll talk about expectations of what the dosing might be, how they're going to feel. It's still recommended with hormone treatment to have the baseline mammogram.
Mhm.
So that's required. And then follow up. I do like to see hormone levels again in a matter of 3 months or so. See how a woman's feeling clinically. How are the symptoms? What's she experiencing? See some levels. And in an ideal world, I'd like to see some extra testing to see how the estrogen is being metabolized in the body.
Yeah.
Because there's good metabolites, Emma, as you know, and then there's possibly some unsafe metabolites. So we want to make sure a woman's body is handling her estrogen in the proper way, in the good way.
Yeah, I couldn't agree more. That's kind of exactly the route
That's what
we
we
go.
can do. So it's
Yes.
super
I know
cool
it's
to do
it's
that.
cool now, we have the technology and medicine is advanced. Back in all of the studies, they gave, I think the average woman's age was 65, where they gave them the hormone. That was the Women's Health Initiative, which kind of drummed up all the fear. And I think it's important to have the conversation that women need to feel comfortable with the therapy that they're doing. They should never feel pressured into it because at the end of the day,
Absolutely.
medicine should feel right for you. And so just because someone else is telling you it's the way to go, it should always feel like it's something that you really feel
Yes.
aligned with.
That's a
And
really good point. If there's a woman who's really fearful about hormone therapy and no matter, the data that's been presented, et cetera, she still is unsure, then we won't go there because that's stress in her mind that is going to do something bad for her health. That's not good.
exactly, I
So it's
totally
got to
agree.
be individualized. The real point is it's got to be individualized therapy for each woman and her choice with her prescriber of what she wants.
I couldn't agree more. And also really making sure clinically, that they're, and that's a conversation. Like of course we look at blood levels to make sure we're giving doses because every woman's absorption is very different. You can give one woman the same, like 5 women the same dose, and their blood levels will all be very different. And because they have different absorption, metabolism, so it is important to look at levels, but it is more important to ask a woman, how are you feeling? How are you doing? And so we use the levels to dictate, okay, you're still having some symptoms. Is it safe for us to continue to go higher? And so that's where we kind of use testing, at least in our practice, to kind of dictate and navigate the threshold. And so you understand as well what's happening in your body.
Mm-hmm. Yeah, I think it's important to highlight too that my wish is that we get women in their early postmenopause rather than in their mid 60s coming to see us, because the safety data is very robust. Just recent, postmenopause. There's a lot of great safety data in terms of, the risk for breast cancer and heart disease. But once a woman's in her mid 60s and wanting to start hormone therapy, then we don't have the good safety data to say absolutely it's not going to be problematic for you. In fact, it could potentially be risky. So my wish is always, let's educate the women in perimenopause, in early postmenopause, get them there, and they'll do well.
Yeah, exactly. Because we know that that's when the big drop happens, and that's when the biggest changes happen in bone, cardiovascular health. And I think if you look at the Canadian guidelines for women who have gone through premature ovarian failure, when their ovaries start to shut down in their 30s, late 20s, that's a condition that can happen. It's really strongly encouraged for cardiovascular and bone health to immediately implement hormone therapy. And again, women should really strongly be educated. The earlier you transition through, you've got a really long life ahead of you. And so you don't want to have to be dealing with those big changes 10 years down the road. You might not feel it as much because you're young, but bringing those levels back in can have such a significant impact on. So there's women going through menopause 40s, I've seen it multiple times. And those are the women I really want to educate on bringing hormones in.
Right.
Yeah. Awesome. Well, thank you, Grace. Anything else we want to add? I think we're good. We talk about the safety. Again, we always do a screen for every single woman on whether or not they're actually a candidate, because not everybody is a candidate for hormone replacement therapy, but that's something that you need to have individual conversations with your practitioner about.
Absolutely. Absolutely. It's individualized. Have the conversations, get the information you need. Women shouldn't have to suffer. There's help.
There is help for sure. And last point I want to make before we finish up is vaginal estrogen is not hormone replacement therapy. I say this a lot. If your main symptom is, we're working on everything else, but you have significant vaginal dryness, pain with intercourse, giving a little bit of estrogen vaginally is not considered a hormone replacement therapy. It's not considered estrogen replacement therapy. So we can initiate that very quickly, safely, and we don't need to pair it with the progesterone. And I just want to say that so women know, because we do it all the time, and they're afraid even vaginally to use a tiny dose of estrogen, and it can have such a huge impact.
And you're not getting systemic levels of estrogen with that low dose vaginal estrogen at all. It's just staying in that vaginal tissue, restoring the pH, strengthening the pelvic floor muscles. It has such a great effect there.
For sure.
Yeah.
So I think that's a good spot to end off with. Thank you so much, Grace. I love talking to you about hormones, and thanks.
Well, every day is a good day to chat women's health.
That's right. Thank you for tuning in, everyone. Have a lovely day.